Okay, today is Tuesday, September 25th. Brent Mueller and I are here to review the mentor training I did with Brent on Thursday, September 20th. Then the first thing I want to say is I think you did an excellent job. I think you have good rapport with the patient. You present yourself well. You acknowledge and validate the patients. You treat them as an equal, and also the family members. Patty's husband was there, and I thought you did a nice job with him as well. And you have good demeanor that not only the patients recognize, but we as a staff recognize it as well. And as you get to know more in the community and the referral sources, I think that's definitely an asset of yours that will help you out a lot and help the clinic be successful too. So here is the mentor report to the clinic director that the mentor fills out and then sends to the clinic director. And, so I was the mentor and I'm your clinic director. So so personal education plan, that's one of the things that we'll want to develop. And on that day we saw, I think, 3 patients and clinical topics reviewed. We saw a couple patients with some different stages of arthritis. Patty had a little more advanced stage, and Josiah? Yeah. Probably had some earlier stages of arthritis in his knee. We discussed ankle joint mechanics with Pete. Was that his name?
Yeah, Peter.
Posture with Patty. Knee strength, stability. One of the patients had a meniscectomy. We discussed core stabilization, facilitated segment concepts. So strengths, I mentioned this, develops good and immediate rapport and relationship with the patient and the family. And that comes in handy not only for that immediate episode in time that you're with them, but in the future. It builds validity and trust. And then when you are working with the patient or need something from the patient, then it just it's almost like a bank. You're adding up pluses in the bank, and I think that makes a big difference. You collected and synthesized information to develop your hypotheses. We didn't have a lot of time to review things before the patients were here, so I was reviewing the initial evals, if there was a re-eval, and I think you did a nice job of collecting information off the history, synthesizing that information. It looked like some of the information that might not have been provided on the history forms, you were able to, in your interview, collect that information, and through your clinical exam, get more information. So, and that makes me think one of the things that I'll want to do the next time we do some mentor training is to watch an eval and watch reevaluations. Use clinical reasoning and analytical reasoning to begin to see pattern recognition. We talked about the arthritis and the different stages of arthritis and what that can look like in different people in different forms. Personally, I kind of always reflect back and use as an analogy near stages of impingement and how in the 20-year-old what it looks like, and then as they get into middle age and later age, I kind of will use that as an analogy to arthritis or other degenerative type of things. And I like some of Shirley Sarman's discussions about impairments and how they can lead to disability, and then how the impairments can lead to disability, and some of the things that we can do to help prevent that, and to justify the need for therapy or maybe continued therapy or something further down the line to help prevent things from becoming worse. Next stage in development, strategize treatment time to increase time management and efficiency. Use structure to your advantage. So, like that, that patient is in some ways a captive audience for you, or a lot of times they're looking for you to guide the program as opposed to letting them kind of control the treatment time. A lot of patients will want to talk and talk a lot, and that's okay. You do a nice job of, like I said, acknowledging them, validating them, let them get their word in, but then helping them realize that there's a certain limited amount of time.
Redirecting them a little bit.
Exactly, and then you can get through to them that you honestly, you care about them, and because you care, that you want to do the most you can in this time that you have. And that takes time and experience. I can remember as a young clinician just letting people talk, and I finally got to the point where I had to stop them. And now I'll during an exam I'll say, we have this amount of time. If you want to keep talking, that's fine. If you want to do what I need to do, then I need you to make a decision as to what you want to do. And that way, it goes back to them as far as helping them feel like they're participating and not being passive. So it's more of an equal type of thing, but they a lot of times will need some guidance through that.
Yep. And I think along with that, each patient is different, and we'll need to talk through it a little bit more, and some a little bit less.
Yeah, and that's true. There's different personalities, different communications, and if you come in and just try to shut somebody down, they may not like that, and they're going to resist. So if you kind of give them, kind of say, okay, let's talk about these things, for these first 2 minutes, and then we'll get on to the procedure or something. But use your own style to come up with something like that. Or if they can start with a warm-up, like on the treadmill or on the bike, sometimes I'll do that, and it's like, let's talk about this as we do this, and maybe it's manual treatment, either some things in the room or not in the room. Let's see. Use your clinical and analytical reasoning to recognize common and uncommon patterns and test your hypotheses. So, just for clinical reasoning, analytical reasoning, some things might seem pretty straightforward and simple. Other things can look that way and might not be. I always say, does it seem musculoskeletal? Is it appropriate for care? You've gone through some of the NIAM classes, going back to the exams and how they go through things will be helpful. And engage in critical self-reflection. Think about what you did in the treatments, how the patients are doing. Here at TAI we have some structure to help with that. The utilization reviews can help, and it's nice to have other therapists here to bounce questions off of. And we also have the tool of the listserv to ask a question to out there, and then maybe it's just one case a week, and it's like, okay, or maybe somebody that's on your mind that it's like, I'm not sure what to do with that patient, and kind of walk yourself through that case. So suggested teaching to help you with that, with the hypothesis testing in the assessments. Think of maybe 3 possible things it could be, and then the reasons why you might feel more strongly toward one than the other, and rule things out, and that helps with pattern recognition and uncommon type of things. I have some resources here as far as some books on differential diagnosis, and you're welcome to use any of those. Review biomechanics of the ankle. That was a good reminder for me, so I'm happy to review biomechanics of not only the ankle but other joints, and maybe we can come up with some informal structure where it's like we pick, it's like, okay, every week we review biomechanics of one joint or one motion, something like that. And this was good for me because I think I'm going to start to do some of these things too. Another thing, keep the clinical reasoning form available to use as an informal structure daily. So you can see I have things taped on my walls, and some of them are reminders, and I think I'm going to tape that clinical reasoning form up so I can just have easy access to it and use it for some informal structure in some of the things that I'm thinking about or want to do with the patient. And then assignment, I think you and I to meet formally or informally. We can decide what structure works best for us to meet every week, and we can decide how we want to do that. For self-reflection, verbalize or document the clinical reasoning form on at least one patient weekly, and I think I'm going to start to do that too. And having it up there, I'll be able to kind of go through it for myself with that form. And then if you haven't developed the personal education plan, let's go ahead and do that, or figure out how you want to do that. You can write it up yourself. We can arrange a time to talk on the phone with David Depler. If you want, I'm willing to sit down and talk to you. If you want my help in it too. So a question I should have asked you when we started is, how did you feel things went?
Yeah, I thought it was good. I think it was helpful to have, just like when David was here a couple weeks ago, it's always helpful to get you thinking a little bit differently about things and kind of see what other therapists' ideas are on certain things. Very helpful.
Good, yeah. Like I said, I am very impressed with your skills. I think you have great skills and great potential to improve them. I'm glad that you kind of recognize this is where I am, this is where I want to be, and some of the things that it takes to get you there, and we'll do anything we can to help you out. Okay?
Yeah, very good.
Very good.
Thanks, Jeff.
Thank you. And thanks, Bill.
Yeah, thanks, Bill.